So I ran 40 and 89, and his pain went to 0. Yep, 40 and 89. I said, you tore the nerves to your big toe, and you basically have phantom limb pain in your toe, like the nerve got cut. He said, really? Trigger points in the upper trapezius are never from the upper trapezius. They're always from something. Historically, patients who have problems with smell have a higher incidence of dementia. It is one of the predictors. I just want to share with you how it was I trained myself to have intuition, how it was I trained myself to see inside with my fingers. Aha.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Pittis.
Hi, everybody. I'm all by myself today because Kim is on the East Coast and is in the middle of something and can't come on. So it's just us. That means you get to ask questions. That means I get to start with a story where I get to tell on myself. Remember how I told you to always take a history? You know how that's like a theme. I had a patient last month. I took his history. I had low back pain. I had high leaf. I had foot drop. And then I had low back surgery. No, I had leg pain in my foot. My calf got really tight. And I got foot drop. And then I had surgery. And I didn't have foot drop anymore. So I just treated him for sciatica pain, nerve pain, 40 and through 96. And then he was the one where I found out that there's 2 different cutaneous nerves that go to each side of the big toe, that the big toe has 2 nerves that make it hurt. So that was last month. He came back up this week, as a matter of fact. And Monday, he expanded the history. Now, remember how I said the patient won't know what's important, so you have to ask them? I never slowed him down and made him tell me exactly how it happened. He did that Monday. He had pain in his foot and nerve pain, and then his calf got really tight. And what he told me Monday was he stretched his calf with a rubber band, those band things. And then he pushed his foot down, and then he pulled it back up, and then he pushed it down, and then he pulled it back up. And then he got foot drop. Excuse me? Then you got foot drop? Yeah. And then the foot drop got better. The toe pain stayed the same. The foot drop got better, and then I had surgery, and that helped about 20%. Excuse me? The foot drop got better before the surgery? And I'm thinking to myself, I didn't ask him that? Okay. And then after the surgery, the toe pain remained. Sciatica got better, but the toe pain remained. And he said, it hurts worse at night. As a matter of fact, during the day, it's like a 4 or 5. But at night, it's like a 7 or an 8. And I can't stand to have even the blanket on it. Now, someplace, somewhere, in the core or the advanced, it should say that pain that's worse at night is central, right? And he kept saying the pain is so much worse at night. So Monday of this week, I ran 40 and 89, thinking, what if in the process of stretching that foot up and down, what if those two cutaneous nerves that come out in between the fascia and the tibia, what if that nerve got caught in the tight fascia? Because he's an athlete. What if that nerve got caught and it tore? Then it would be like phantom limb pain. So I ran 40 and 89, and his pain went to 0. Yep, 40 and 89. I said, you tore the nerves to your big toe, and you basically have phantom limb pain in your toe, like the nerve got cut. He said, really? Yeah. So he brought his custom care that he bought last time, and this time I put night pain right at the top. And he came back Tuesday morning and said there was no pain last night, and I woke up with my pain at a 1 this morning, not a 7, a 1. He has phantom limb pain in his big toe. This is a first in 30 years. And I didn't figure it out a month ago because I didn't ask him the right questions. Tell me what happened in what order. So the little voice in my ear that should be my voice in my ear didn't tell me. Or if it did, I didn't listen because I was so convinced I was so happy that I figured out there were two cutaneous nerves to the big toe. That was like a big deal. And I kept treating it as if it was nerve pain. Never occurred to me that he had torn the nerve because I never asked him about what did you do? And when does it hurt? And the foot drop got better before the surgery. So there, I'm just outing myself. And let's see. I'm not sure it is. I used DNA. Goody, we have a question. I used to have a snap, crackle, pop existence where I couldn't be stealth in any way. Last night I noticed the knee pop was back. I'm assuming it was an FSM protocol that took those away. It's been a while since my last visit. What protocol should I ask for next visit? I don't know. Ask your practitioner. So this is a patient. Ask your practitioner and what she ran the last time she was there. I don't know what the snap, crackle, pop is from. So I would say ask whoever treated you last time, assuming you're going to go back to see the same person. Yeah. Okay. Somebody has to ask me a question, or I'm going to have to just keep talking. Let's see. What else can I talk about?
Do you have anything from last week?
Do you have anything from last week? Do we have anything?
Thursday or Friday?
Thursday and Friday. Ooh, that was so long ago.
I know.
Yeah. Usually by the end of the week, they're doing better. This week, do you ever start with liver support instead of liver toxicity? Yeah, they're the same thing when you think about it. The liver, that's a good question. Liver support instead of liver toxicity. Usually the thing that makes the liver funky, I think is the technical medical term for it, is toxins, anesthesia, unless it's long COVID. It just depends. When did your liver enzymes go up? There was that guy from last week. What was his thing? That's a chart. It's gone. He mentioned on the last day that he had, oh, I know, he was the one that had increased secretions in the pons to take care of the spasticity and 40 and 89 to take care of the body pain. And then he mentioned that I also I was self-medicating. And so they say I have cirrhosis. Excuse me? He said, yeah, my liver enzymes are normal, but the scan, so they did an ultrasound or some sort of scan, said I had cirrhosis, and those two don't match up. If you have cirrhosis, usually your liver enzymes are elevated. And so they biopsied it, and sure enough, they said he had cirrhosis. But usually, if you have cirrhosis, the liver is enlarged. So I palpated under his ribs, and his liver was not enlarged. I had to reach up under his rib to find it, and his liver enzymes are normal. So I put the protocol for cirrhosis on his custom care. And that includes toxicity. So I said, what were you self-medicating with? He said alcohol. I said, well, that's a good way to get cirrhosis. So cirrhosis includes toxicity, anesthesia, opiates in his case, because for some patients, there's an enzyme pathway in the liver that detoxifies alcohol. And the reason that alcohol is good for pain, besides the fact that it numbs your cortex, the reason that alcohol is good for pain is that there's an enzyme that metabolizes alcohol. And in most people, one of the byproducts is acetaldehyde. It's what gives you a hangover and a headache and makes you barf. But in some people, that pathway takes a side channel and skips acetaldehyde and turns alcohol into a substance. It's 3 letters. One of them, the first one's a T. I can't remember the other 3. It turns it into a substance that binds to the morphine receptors in the brain. And I learned about this by reading a book called Beyond the Influence. So those of you that are taking notes, read about Beyond the Influence. So if he was self-medicating his pain with alcohol, maybe he's heterozygous for that enzyme, and he has half of the pathway that goes to acetaldehyde, or maybe his pathway goes to morphine. It goes to a substance that binds to the morphine receptors. So there are certain kind of alcoholics that they're binge drinkers usually, and they're really hard to get into recovery because they never have a hangover. Aside from doing stupid stuff and getting DUIs, they don't get a hangover. They have no metabolic consequences. They're addicted to morphine. So that's why the cirrhosis protocol includes the 3 frequencies for morphine. Liver support usually includes toxicity, anesthesia, increased secretions, reduce inflammation, chronic inflammation, fibrosis. Cirrhosis includes 58, which in the advanced is degeneration, 54, which is necrosis, 97, which is adipose, because cirrhosis, healthy liver cells are turned into adipose fat and scar tissue. But the nice thing about the liver is it's the only tissue in the body that regenerates itself. So it is not beyond possibility that cirrhosis can get better if you reduce the inflammation treat the necrosis a little bit, treat the toxicity, treat the opiates, treat the fibrosis and the scarring and inflammation in the adipose as well as inflammation in the liver. I'm not sure if I put cirrhosis in the new custom care mode bank or not, but so I don't know. I guess I usually start with liver toxicity. I did with someone I was worried about poor diet, alcohol, decided to do it that way. Didn't know if it was appropriate, then to toxicity. That sounds like a good plan. It's like you can't go bad with the liver. When you do the liver, when you treat the liver or you have someone with liver issues, you want to support the stable state. Lipoic acid is a big one, and acetylcysteine is a precursor to glutathione. If you look at the two slides in the core that are about the liver detox pathways that say the liver is a busy place, B vitamins, vitamin C, all that stuff, but lipoic acid and milk thistle. Lipoic acid is the active ingredient in milk thistle. So those of you that prefer herbs can use milk thistle. I'm a biochemistry guy, so I use lipoic acid. I remember hearing an interview with the physician who found out that if you do a lipoic acid IV, 100 milligrams, after someone has Amanita mushroom poisoning, you can, and you do that IV 3 days in a row, they don't need a liver transplant. That sort of has stuck with me because at that time it was in the news that people were dying of Amanita mushroom poisoning, and he had the solution. So there. Liver function within normal and limits. Wow. Kathleen Casman. Liver function within normal limits. That means the enzymes are normal. So let's just back up a little bit. Liver enzymes are elevated because the liver cells break open and the enzymes that should be inside the liver cells doing their liver thing, when the liver is falling apart, those enzymes go out into the bloodstream and you have elevated GGT, AST, ALT, and ALK-Phos to some extent. Non-alcoholic fatty liver, thoughts on treatment. There's a protocol for non-alcoholic fatty liver, and that's a David Musnick thing. It's reducing carbohydrates, something to do with excess carbohydrates doing something bad to the liver. Non-alcoholic fatty liver condition or disease is because patients basically get too much carbohydrates. They need to lose weight. Those two slides in the core, pretty sure they're in the core. And so there's a protocol for non-alcoholic fatty liver, and I haven't seen it in 22 years. No, actually, but 15 years. And I treated it unsuccessfully because the girl was 40 plus pounds overweight and refused to cut down on carbohydrates. Didn't think that non-alcoholic fatty liver was a problem. And I lent her my auto care and had her run liver toxicity and liver fibrosis, supposedly 3 nights a week for a month, and came back and her ultrasound was still positive for non-alcoholic fatty liver and no change whatsoever. Yeah, I don't know. I'd go with the protocol for non-alcoholic fatty liver, Kathleen, but I'd also look at the diet, carbohydrate intake. The patient will get a continuous glucose monitor. That would be a good idea. So she can monitor her blood sugar and see what drives it up. You have an app on your phone that lets you that connects to the CGM and see if that helps. Because without stable state being created, I don't know how to fix it. It's a really good question. I just don't see enough of it to know, mostly because my patients are here for a week and fixing non-alcoholic fatty liver takes a couple of months, as far as I can tell. Okay, next. Thank you guys for asking questions. Hello, Lisa. How do you release trigger points in your trapezius? How do the traps contribute to or create nerve pain, rotator cuff pain in the shoulder? You release trigger points in the trapezius. 40 and 94 quiets down the tension in the trapezius, but it's the other way around. Rotator cuff problems cause the trapezius to tighten. So back when I had my shoulder fracture, when we were doing rehab for 14 months, one of the last steps was getting my lower trap to contract. And that was after we fixed the rotator cuff partial thickness tears. The upper trapezius contracts to keep you. So everybody that's watching, raise your shoulder up and now try and move your arm. You can't. So the brain, I think, and my experience with myself as a patient was upper trapezius. It tightens the upper trap to keep you from moving the shoulder. So the way to fix the upper trapezius is to fix the shoulder first. Repair the partial thickness rotator cuff tears, do the subscap, so do the whole supine cervical practicum, repair the rotator cuff tears, and then teach the patient to contract their lower trap. So stabilize the shoulder blade from the bottom, and almost 100% of the time you tell them, bring your shoulder blade down towards your waist, and they do this. It's no, not that one. That one. The one down there below your shoulder blade, and you have to pinch it so they can find it because they've been like this for a really long time. So fix the shoulder first, then teach them to contract the lower trap, and you can run 40 and 89 and see what happens. Trigger points in the upper trapezius are never from the upper trapezius. They're always from something. Someone I knew might not tolerate feeling the detox first. Oh, detox reactions. The reason I tried it that way. Yes, I have him on milk thistle. Did he have a detox reaction, Annie? I don't know. You're welcome, Kathleen. Thanks for the science. The thing is, when we run liver toxicity or toxicity in the adipose or toxicity anywhere, the reason that the model we have for how the frequencies work is that it changes cell signaling. When we run the frequencies for toxicity in the fascia, toxicity in the adipose, toxicity in the whatever, patients don't have detox reactions. And if we were releasing toxins, they should have, right? So what I think is what we're doing is changing the effects of the toxins on cell signaling, right? The toxin lands in the membrane and makes the receptor go cattywampus. And then over time, the toxins are released from the membrane because the cell membrane replaces itself, but it replaces itself with the receptor cattywampus. And then the frequencies come along and go. That's the only way I can explain how we run toxicity in the fascia. Remember in the core, the guy who has cat litter in his infraspinatus and teres fascia in his shoulder after picking pears and nickel off orchard, and they used pesticides. And I ran the frequencies for toxicity and all the knots went away, but he didn't get sick. So that's what we think. That's what he thinks too. That's what made me think that we're not releasing actual toxins from the system. I've never had anybody have a detox reaction, actually, not since the beginning. And not sure if it helped him to do it in that order. He reacts to many detox approaches, hence my choice. He did not react, but was curious if that was helpful and not just coincidence. I did have a client who did react with nausea to liver detox. Oh, okay, finally, somebody who reacted with nausea to the liver detox. Interesting. Wonder what that was from. They have a history of toxicity exposure, anesthesia, because I've never had anybody react with nausea to running liver detox. So that's a first for me. Interesting. That's interesting. Nausea. With chemotherapy causes nausea because of toxicity in the midbrain. So why would running liver detox protocol, which includes removing toxins from the liver, why would that cause nausea? Because it's not local. It's not toxicity in the stomach. It's toxicity in the brain. Wonder how that works. I don't know. That's a good question. Because if you run toxicity in the liver, if anybody can think of anything, let me know. Because this one's got me stumped. Nausea in response to toxicity is usually in the brain, at least with chemotherapy, not in the stomach. Okay, were you thinking of low-dose naltrexone? No. Useful for IBS and multiple sclerosis, locks into opiate receptors in the brain, which can prevent you from getting drunk. I don't know why I'm on low-dose naltrexone and I can still get pretty loopy on 2 glasses of wine. So no, it's not low-dose naltrexone. It's a thing that starts with a T, and it's a long word. Nausea have anything to do with fats being released into the stomach? Not that I know about, because if you're treating the liver, and nausea can come from your gallbladder not working right as far as fats go, Lisa, because fats into the stomach don't cause nausea. It's when they hit the bile duct and the liver can't cope with them that people tend to get nauseated, I think. I might be wrong. That's a possibility. But back to Leaf. No, this book is worth reading. It's called Beyond the Influence, and it talks about certain kinds of alcoholics have liver detoxification pathways that skip acetaldehyde. And I had a friend who was that kind of alcoholic. He had literally lethal doses of blood alcohol, lethal levels of blood alcohol at one point. And yeah, like 3.8. And that was 4 hours after his last drink. So at some point his blood alcohol was 4 point something, and at 4.0 you should be dead. And he didn't even have a hangover. It was pretty amazing. We read the book Beyond the Influence, and it explained the liver detox pathways that turn, instead of going to acetaldehyde, which should give you at least a hangover, he should have had a really bad headache. Instead, he woke up feeling just fine after he got out of the emergency room. So that was a thing. I didn't know low-dose naltrexone would prevent you from getting drunk. They have me on it for an autoimmune condition that I've got, and I didn't know about using it for IBS, but I guess to quiet, well, in MS, that makes sense. They use low-dose naltrexone to quiet down the immune system. As far as, can I talk about treating TMJ? In the core, we have two different approaches. My approach is just based on mileage. I was working in a dentist's office in Denver. He let us use his amphitheater lecture hall for a core. And as a thank you or return for his letting us use his amphitheater, I worked in his office for a day and I got to treat TMJ patients. And there was one patient that every time she opened her mouth, both condyles would just click and dislocate, lock, wait, and then they would pop back. So this pop when she went out, pop when they went back. And I did my treat the muscle, treat the nerve, treat the muscle, treat the joint, didn't do anything. And then he had a pantograph up, and there was a really thick white line here at the bottom of her lower canines. And I looked at a pantograph as an x-ray that you take this way, and it gets both the upper and the lower teeth, and it shows them on a rectangular piece of film. And there were these two white lines right there. And I said, what are those thick white lines? And he said, that's the ligament that holds the tooth in place. And that's where they put the attachments to her headgear. And I asked her, so you got TMJ after your braces? And she said, oh yeah, that's when it started, was after the braces. Okay. And I remembered the part of what causes trigger points, because she had trigger points in the masseter, the temporalis. I had her palpator pterygoids, and they were just exquisitely painful, but you could feel the trigger points in her masseter and in her temporalis. It was just like cat litter. And I thought torn and broken in the tendon works for trigger points in the shoulder. So I wonder if torn and broken in the ligament would work for trigger points in the jaw. So I had her put contacts on either side of her jaw, face, either side of her face, and we ran 124 and 100. And first thing that disappeared was the trigger points in her masseter. And after about 15 minutes, I had her open her jaw, and one side didn't pop at all, and this side popped only when it went back. Then I treated torn and broken in the connective tissue, because the pterygoid attachment to the disc is connective tissue, it's flat. And so I did torn and broken in the ligament for about a half hour, torn and broken in the connective tissue. And at the end of 60 minutes, she didn't have any popping. All the trigger points in the muscles were gone. Kim's approach is more complicated, because she took a class on TMJ, and they talk about the fat and the blood supply. And so she has a lot more tissues and a lot more conditions to treat the TMJ. You want to treat torn and broken in the disc, because when the pterygoids pull the disc out as you open your jaw, it pulls it out, and it doesn't let it go back in. So your condyles roll back while the disc is still pulled out, because the pterygoids are so tight. And Lisa said, what causes the trigger points? The torn, in my world, the torn and broken in the ligaments, and the torn and broken in the pterygoids. Because some people get TMJ after wisdom teeth removal, or after a bar fight, or hitting their jaw on something. And if you think about what happens to the connective tissue that holds the pterygoids to the disc, they get stretched, and that creates tightness in the pterygoid on one side or both, and that pulls the disc out, and that's why it pops. And once it starts popping, then you have a disc injury, and the masseter and the temporalis get tight to keep you from opening your jaw, if you think about it, right? Body wants to protect that joint. And once it's tight, you increase tone, the muscle runs out of energy, and you get trigger points. Takes 3 ATP to contract a muscle, takes 2 ATP to relax it. If it's so tight that it uses up all its ATP, it's not supported by any research I've ever seen, but my idea about it is it just can't relax because it runs out of energy. And once you have a taut band, then you just build up metabolic waste and you end up with trigger points. So what are trigger points? Once again, this is all on the core. A trigger point is a focus of hypercontractile tissue where there's an accumulation of metabolic waste. And that's a thing. Go back to the core, Lisa. You have access to it if you took you took the core. So go back to the core slides, you'll have access to them. And just look up the two approaches to treating TMJ. There's no reason you can't do both. As a matter of fact, it's probably a good idea to do both, torn or broken ligaments, torn or broken the connective tissue. And then you can treat the joint, which is actually Kim's approach. Treat the fat pad, treat the blood supply, treat the disc injury, treat the cartilage, treat the periosteum. Is the eczema frequency pair time dependent? Alice, I don't know. I haven't treated eczema in a really long time. And eczema it's a 48 constitutional type. It's an allergy reaction. It's histamine and inflammation that shows up in the skin and the capillaries. Most of the time, it's a result of inflammation and leaking in the gut and overactivity in the immune system and a release of histamine. So it can be a manifestation of MCAS. So you're treating histamine in the capillaries, the skin, the immune system. And I would say it's time dependent, but the other thing is you have to treat the gut. It's leaky gut, and that activates the immune system and macrophages and release of too much histamine. So it's it's like a 3-machine thing: leaky gut, MCAS, and then when I was treating eczema back in my days when I had a general practice, I had inflammation and histamine in the skin and the capillaries. The hives went away and they were back by the time she got to the parking lot. So it's creating a stable state that is a thing. So so you treat the histamine in the skin, inflammation in the skin, leaky gut, quiet the immune system, histamine in the immune system, histamine in the blood, histamine in the blood. I think that's the other thing. And I would guess it's time dependent because eczema doesn't come from space, right? It's what did you do just before you broke into hives? If my lesson for the week is anything, it's the patient with the torn nerve root where I didn't ask exactly what happened in exactly what order, what came first. That's a thing. So ask the eczema patient, what do they eat? Where do they live? Think about it. Are they positive for mold? That's a thought. What do they eat? When do they eat it? When did the eczema start? Are they sensitive to dust? There's so many causes. There's that. And this is where you might want to talk to David Musnick during the break at the advanced and ask him about that. Jillian, seeing you at the advanced in March. Oh, me too. I'm so excited. That was really fun. I turned to my slides and then of course I thought of some things I needed to add. And there's Kevin over there going, yeah, like I'm surprised. Treating a patient currently post-ACL reconstruction, patellar tendon repair, poor baby, having pain in the patellar. What? Wait, he had an ACL reconstruction and a patellar tendon repair, and he's doing squats? Of course he has weak quads. Okay, I'm calm now. Question as I treat with 124 and 77. No, yeah. Of course he's going to have pain with squats because he's stretching a tendon that was torn. Of course, one of the things I don't know is how long afterwards, but how did they repair the patellar tendon? There's that. And ACL reconstruction, you might want to do 124 and 100. Is there any way to tear the ACL without traumatizing the meniscus as well? So maybe 124 and 214, the meniscus, that might be a thing. Yeah, no, the solution to this, Jillian, is no squats. No, you don't get to do squats. No, no squats. No. He can do sitting quad strengthening, sit with the little machine and lift your leg to strengthen the quads. You can do that because that doesn't put your body weight on the tibia and stretch the hell out of the tendon. No squats. Yes, it's more of an 81 and 84 thing. 40 and 89, yes, but the biggest problem is he has no business doing squats. Oh, okay. Patellar repair, use the patellar tendon to repair the ACL. Yikes. Okay. Oh, here's Jillian's response. Patient is 17. Oh my goodness. Oh dear. Okay. Not a patellar repair. Use the patellar tendon to repair the ACL. That is unusual. Usually they use a piece of the hamstring tendon because it's the right shape and kind of the right tissue. Someone else is rehabbing and fixing the problems they have caused. Of course you are. Okay. So you might mention to the patient that okay, yes, it should make you crazy. So Jillian says she is 6 months out, Division I athlete. Yes, it's making you crazy. Okay. I'm not sure how to do this tactfully, but tell the patient's mom, she's 16, Division I, so mom or dad has a vested interest in having their kid recover. The parent has got to be bringing the kid in because at 16, she can't, 17, she can't drive herself yet. So tell the parent that squats are not appropriate for this kind of injury, and they are paying you to fix the problems that the rehab is causing. I don't know how you do it tactfully. I don't know if you know the PT that is rehabbing them, or most likely it's a trainer. I hope it's a trainer. I'm hoping no physical therapist would do this. One never knows. Oh, yeah, I'm really sorry. I know what I do, but I don't know what you can get away with in the social, political environment you're in. But no squats. It just, She can go to the gym. She can do, quad sets. That's okay. And as a matter of fact, she shouldn't be locking her knees, even just strengthening the quads, because every time she does a squat, she injures the ACL again. messes with the meniscus and injures the patellar tendon. You poor thing. I don't know what to tell you. It's wow. Tell them to bring her to you 3 times a week, and maybe then she won't have time to go get beat up by the other rehab person. I'm really sorry. That's hard politically. Yes. Yes, I've had that conversation, but when getting to the point of retraining, how long do we run? Restore coordinated movement. Oh, how long does it take to hold typically? You got to fix the tissue first. The restore coordinated movement, you got to fix the torn tissue first and restore coordinated movement in the pain-free range. Right? It takes maybe 15 minutes of 40 and 89, and then 81 and 84, 81 and 10. 81 and 84 is maybe 15 minutes while she's moving it in a pain-free range. So you have her sit up on your table with something around her neck, wrap around her foot, and have her move the knee in a pain-free range with no weight on it, and just get the quadriceps to fire, and the brain will learn it doesn't hurt. You've had that conversation. I'm so proud. When you're getting to the point of retraining, you have to strengthen the quads first without squats. No squats. I don't know what her sport is. If she has to squat as part of her sport, you have to repair. The tendon will strengthen with quad sets on the machine or even with bands. And eccentric contractions are actually the best way to strengthen the tendon, but that's another conversation. That would be hamstring curls, right? Because that's eccentrically contracting the quads. Does that make sense? So you do quad sets to strengthen the quads with the patient seated, not squatting, and then hamstring, maybe even hamstrings first, because that's eccentrically contracting the tendon. And there's pretty good data on that's how you repair it, at least an Achilles tendon. That's the study that was done, was eccentric contractions of the Achilles repaired Achilles tendinopathies. So I'm assuming that eccentric contractions of other connective tissue would work as well. It can't be 455. TCA, citric acid salad, trying to look it up for me. Okay. Yeah, it's cytochrome P450, 2E1, I don't know, catalase, leaf. That's the alcohol thing. Jillian, good luck. Congratulations on the fighting the good fight. And you won. That's good. Oh, hallux rigidus, massive arthritis, just surgical solutions. The problem is the surgical solutions are not great either. Having had hallux rigidus and a bone chip in the joint, they did the surgery and the joint fused post-op, which was a thing. What's a chelectomy as a first option? I'm not even sure. And I'm not sure what Cartiva is. You got me. I have my phone. I'll look up chelectomy. Kate Adams, hang on, Annie. When she worked in a TMJ clinic, a lot of the people that had TMJ usually had braces. That's the truth. This is new since I went through menopause, but I have Hashimoto's too. Yes, it's the immune system gets out of control, and your immune system decides your thyroid belongs to somebody else and develops antibodies to it. Hold that thought. New client with dementia who put on the history form that the dementia is coming from a lack of coating on the nerve. What? What? Okay, lack of coating of the nerves in his frontal lobe. I'm not sure where he got that. That's a good question. Lack of oxygen, he thinks that's the vagus. No trauma, stress, or illness in the last 18 months. Not much for the whole 70 years. Very uncoordinated. Whoops, no sense or recognition of smell. Only did history, brief eval. Question. When it did he get vaccinated for COVID or did he have a cold? When did the lack of smells, the problem with the sense of smell, when did that start? Historically, patients who have problems with smell have a higher incidence of dementia. It is one of the predictors. And I'm not sure about what makes him think he has a lack of coating of nerves in his frontal lobe. Is that coming from reality or from his dementia? That's interesting. Uncoordinated, he got Ehlers-Danlos, or did he or she have it? You said a him, right?
Yes.
Vegas, that's what his doctor said. Yeah, no, just no. If he got a COVID vaccine, when did he get it? And when did the problem with smell start? So the first thing I would do would be run the COVID frequencies in the vagus. Lack of oxygen, that's the vagus increases oxygen and nitric oxide in the brain and reduces inflammation. You can treat the capillaries and the ethmoid sinus with the COVID frequencies. 475, I'm not sure what that is. Let me look it up. What is 475, you guys? You can tell it's not something I use a lot. I think it might be that nerve sheath thing, right? 475. Yeah, nerve sheath. No, that is there's no nerve sheath in the brain. Myelin might help. So you have peripheral and central myelin, but I would treat the heck out of the vagus and then run inflammation. Inflammation is the basic cause of dementia. We do a whole section on it at the very beginning of the advanced, and is the patient overweight? What is their status as far as insulin resistance and blood sugar? The COVID is the number one. The vaccination is the same as getting the disease, especially if it was one of the mRNA vaccines. They are renowned, shall we say, if you read the Pfizer papers book, for problems with seizures and brain trouble as well as cardiac stuff. So my money's on the vaccine. Find out which kind of vaccine he had. Either way, a vaccine is an artificial infection, and it turns the vagus down because the vagus is turned down by infection, stress, and trauma. So treat the vagus, treat the brain for inflammation, and increase secretions. Put the patient on huperzine A, CoQ10. So the brain has the highest concentration of mitochondria in pretty much in the body. It's 20%, 2% of the body's weight. It's 20% of the body's mitochondria or energy use. Support the mitochondria. And you look at that mitochondrial pathway that we talk about when we talk about statins, and that pathway is what you do for dementia as well. Support the mitochondria with vitamin E, CoQ10, glutathione, and lipoic acid. Pretty sure that's the sequence. So all three of those plus huperzine A, which is an acetylcholinesterase inhibitor, and that gets the vagus to work better as well as the cortex. And if it's only been 18 months, you might have a chance of reversing it. Vaccine was in 2020. Basically, his dementia started 2 years ago, which is 4 years after the vaccine. But you have to wonder, did he have so much intelligence or function? Was his pre-morbid function so good that he could lose 20% before anybody, including him, ever noticed? So yeah, I just go fishing with that one. Look at his weight, look at his blood sugar. COVID's vaccine is the number one when somebody shows up with dementia after vaccine, mostly because of what it does to the vagus. You're welcome, Lisa. I want Roger Billick's brain. I want David Musnick's brain. I want Patrick Wood's brain. Yeah, exactly. Okay, Annie. 1 hour, usually outpatient surgery involving a small incision on the top of the big toe. Oh, that's the kind of surgery. Thank you. To remove bone spurs. Oh, I wish. And tidy up the joint. Yeah. Using minimally invasive techniques. When I have mine in 2000, when was that? Maybe 1993? I'm pretty sure it wasn't that. Synthetic cartilage. Oh, Cartiva is synthetic cartilage implants. Ooh, that sounds like fun. A biocompatible material is used to replace damaged cartilage and restores mobility, avoiding permanence. Wow. Okay. I wish I'd had one of those. It's too late for me now. I had a bunch of 2-inch heels that I had to give away because I can't bend my big toe ever. What procedures are done in the US now? I don't know. So there you go. And it's 4 o'clock. How did that happen? And I'm just talking to myself and you guys, all 32 of you, and whoever watches this on video. Thank you for the Cartiva is synthetic cartilage implants. Do orthopedic surgeons or podiatrists do this particular procedure, Annie? A podiatrist did my toe and it didn't go ortho. Yes, that sounds right. Podiatrists are not always the best option, even though that's where toes usually go. So there you go. Kim will be back next week. I'm looking forward to seeing all of you in March, and I'll comfort Kevin as I add the 2 or 3 slides, only 2 or 3 slides that I need to add. It's like, I just want to share with you how it was I trained myself to have intuition, how it was I trained myself to see inside with my fingers. Aha. And I don't usually tell people that because it sounds pretty weird. And it's really easy. So do it at home. I will show you. I will see you in March. I will see you next week. Kim will see you next week. She'll be back as far as I know. I look forward to seeing everybody next week too. Have a good one. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.